talk today about hepatitis C and why this matters for Massachusetts. So my name is Richard Baker. I'm the Coalition Coordinator for EndHepCMA Massachusetts. And really, we have a simple mission, which is the elimination of hepatitis C in Massachusetts. We say that so bluntly because hepatitis C is we're able to eliminate this. We have the medications, we have the ability to do this. So this is one of the charges of our organization, and we're hoping that you, as a part of being here today, whether you sit in a legislative position or you sit in an advocacy position, that you go to your legislators and ask them to please sign on to this piece of legislation that we're going to be discussing a little bit more in depth today. On our agenda today, we have two speakers for you. We have Kyler, who's going to be speaking with us next, who's going to focus talking on about what hepatitis C meant for him, and then we're going to have Dr. Cami Graham, who works in infectious disease and also is the medical director for Project RISE, give you a presentation about why enhanced surveillance matters for our Commonwealth and what we can do if we were to actually pass the legislation that we're looking to move forward. So rather than taking up more of your time, I'm going to have Kyler start off. So come on up. Thank you very much.
Hey, so I just basically want to let you know from a personal standpoint, I had Hep C. I was diagnosed in 2012 in Florida. I got it via sharing a needle with my wife. That was the only person I'd ever shared a needle with. And I ended up getting Hep C because of it. I was in Florida. I got tested yearly, but since my hepatic function and viral load never showed an increase, they never offered treatment for me. I moved up here in August last year. I got tested in September last year. I started my treatment in October last year, and I was done with it in December. I'm homeless also. I live in a shelter. So I did this a week at a time so I didn't have to worry about my meds being stolen. But it's so easy. I just went in once a week, got my meds, took 3 pills a day, and that was the end of it. I think the only side effect I had was a little bit of fatigue. That was it. But I just got my test done, my lab test done yesterday to make sure that I am cured from it. And it's amazing to know that this simple little process has cured this disease in my body. And there's nothing to it. But we've got to test everybody. The young kids are using this stuff now. When they did the opioid crackdown in 2008, heroin became a lot cheaper. The kids started using heroin. They're using those needles. They're sleeping in these shelters. Hep C it's everywhere, it's out there. And we need to be able to test everybody and treat everybody. It's the easiest thing to do. No side effects, basically. It's so easy. So that's all we're asking is, please test everyone. Thank you.
So I think that's a great way to start us off this morning. I think one of the biggest takeaway messages that you can walk out of this room with is understanding that, one, hepatitis C impacts a lot of people, and around 50% of the people living with it are unaware of their status. There's about 200 to 250,000 residents of the Commonwealth of Massachusetts living with hepatitis C. And like I had mentioned, around 50% of that population, 50 to 70% of that group of people is unaware of their hepatitis C status. Enhanced screening and early screening is what's going to make a difference in making sure that we get people to understand what hepatitis means, understand their diagnosis, and then understand the full range of treatment options and just how easy it is to get treated and get this out of your life, as Kyler's story that he just shared with us really shows us. This isn't something that we need to have moving on 10, 15, 30 years down the road. It's something that we can resolve now, and we have the tools to resolve now. Unfortunately, not enough people understand the state of what our epidemic actually is, and that's why advancing this piece of legislation and getting people to understand through the screening process, what hepatitis C means and what the treatment options are is so vitally important. So moving forward, we're going to have Dr. Cami Graham talk a little bit more about her experience in the treatment world and why she also supports the idea of enhanced screening and what it will actually do to resolve the hepatitis C epidemic in our Commonwealth. So, Dr. Cami Graham.
Okay, thanks a lot. So I wanted to, let's get our first slide. This is who I am. I'm an infectious disease doctor. I've been at Beth Israel Deaconess for about 20 years. And I recently became the medical director at Program RISE, which is a JRI program in Framingham that's recently implemented a needle exchange. And I'm going to be talking a little bit more about why that is important. But I've been involved with hepatitis C for 25 years now, and one of those doctors that has seen a phenomenal transformation from when we used to just nearly kill people with interferon, and most people didn't even want to be tested because the treatment was so awful, to today, as you just heard from Kyler, you have almost no side effects. And so I'm going to sort of walk you through a little bit of where we've come from and why the bill that we're talking about today is so important to support. So you just heard from Rich that we have about 200, maybe up to 240,000 people in the Commonwealth living with hepatitis C. We do think about half of them have not been diagnosed. As you can see, our annual new cases that get diagnosed every year is about 8,000, and this has been studied for years and years. It's not slowing down. Often the data that we see is sort of on a county level, but you can see here, this is now city or town level data, and the darker your town, the higher the hepatitis C case diagnosis or report rate is. This doesn't mean everybody, because there's a lot of people that don't know they have hepatitis C, but this is where the cases are. And so if you got any cases in the town that you live in, you need to go back to your senator, your representative, and tell them why it's important to support this bill for your community. Hepatitis C nationwide kills more people than the next city reportable infectious diseases combined. And so if you look at everybody who dies of HIV, hepatitis B, tuberculosis, and all the other reportable infections, hepatitis C kills more people than all of those other infections combined. It probably takes about 15 to 20 years off of people's life expectancy. And you just heard it's curable. Every death we have in the Commonwealth due to hepatitis C is a potentially preventable death and is a tragedy. And this is why we need to do a lot better job in the Commonwealth. What I'm going to talk today, I'm going to talk about a lot of positive, hopeful things, but I'm also going to talk about how we can do better for our community in this state. Okay. So this is not a new idea. We actually had a law passed, we think in about 2013, but if any of the legislative folks can, what,
2012.
2012. Okay, so that's now 7 years that we've had a law that said everybody born between 1945 and 1965 needs to be offered testing for hepatitis C in that primary care setting. And the reason that we focused 7 years ago on baby boomers was because we had data coming out of the CDC from about 2010, 11, showing that that birth cohort, those of us that were born in that 20-year time span, had a 5 times higher rate of hepatitis C than everybody else. And about 25% of those people actually had advanced fibrosis to cirrhosis, and it was urgent to find them and treat them so they didn't die of liver failure or liver cancer. And so that's the rationale for why we had the law for baby boomer testing. We're skipping to the
It's
questions.
real far.
Okay, I was like,
We are not done.
I got a few more things to tell you. Okay, so I'm just showing you some data from Beth Israel Deaconess. We implemented baby boomer testing, and just a little aside, if you've gotten health care at a health center somewhere in Massachusetts, you almost inevitably have an electronic file, and you have a dashboard, and you have little reminder things on your dashboard. Maybe you need a flu shot, or you need a mammogram, or whatever other routine health testing. At Beth Israel Deaconess, we put in a reminder for all of us born 1945 to 1965 that these people needed hepatitis C testing. We put the reminder in, and within a month, our testing had shot up about 400% in the baby boomers. And this costs nothing. Every hospital, every health center has the ability to program these things because we have to do it for our, our general sort of quality measures and everything else. We've tested over 80,000 people at Beth Israel Deaconess now. Keep in mind, the test is cheap. This is not what's driving the cost. But what we realized as we've tested these thousands of people is we had people who had been at Beth Israel Deaconess for years, getting their blood pressure checked, getting all of they think they're getting good care. No one had ever tested them for hepatitis C because it wasn't apparent that they needed to be tested. When they came in to see me or the other hepatitis C providers, we had to tell them what hepatitis C was because there's a lot of shocked people we found. And sometimes we had to tell them, and this is what cirrhosis is. And a few times we had to say, and this is what liver cancer is, because by the time they got tested, they already had liver cancer. We had about 2,000 people kind of backed up in the system before the great drugs like Kyler was telling you about came out. And it took about 16 months for us to treat all of those people. A handful of people, the virus came back, and then we just treated them again with a slightly different regimen. We've cured just about everybody in our system. So when Kyler says, this is transformative, this is easy, it's true. Now I'm going to tell you, what I've realized over time is not everybody wants to come in to see Dr. Graham at Beth Israel Deaconess because people don't like to come into Boston. Our traffic is terrible, our parking is too expensive. And so how do we bring treatment to the people? I'm working with Lynn Community Health Center. We have some folks here from the other community health centers who are trying to expand treatment. So Lynn has about 1,400 people they know have hepatitis C. They've valiantly treated about 200 or 300 at this point, but that's still a whole lot of people left that need treatment. And they're now training primary care doctors within their pods to become little sort of hepatitis C mini specialists to do that treatment, under supervision of a couple of the experts that are there. And that needs to be expanded across the whole state. So we've got technically the infrastructure to handle this epidemic. There's a few things that need to be improved. Okay, here's the problem. Massachusetts was the first state to show that we didn't just have a single peak in the baby boomer group. We had this extra peak in the younger people. And over the years, that peak in the younger people has gotten bigger and bigger and bigger. I actually think we're doing a good job finding our baby boomers. Most of the major health centers now have programs like I described at Beth Israel Deaconess, where they've got prompts and ways of doing the baby boomer testing. And so I think we've tested a lot of folks, and that testing is going on. But our new crisis is in our young people. And we've got a few problems. One, unlike baby boomers, where about 2/3 are men, 1/3 are women, this is about 50-50 men and women that have hepatitis C. And you see that little bitty bump there around the number 1, that's babies, because hepatitis C can be transmitted from moms to babies. What we do if we have a young woman is just try to get her onto treatment as quickly as possible, because if you're treated and you're cured, you don't transmit hepatitis C to babies. You don't transmit hepatitis C to anyone when you're cured. You in fact If you haven't developed cirrhosis, you go back to the pool of people who never had hepatitis C. And I'm able to say, day after day, as people get cured, I'm now putting you back into the pool of people who never had hepatitis C. And that's a powerful message to be able to give people when they know that they have it and can access treatment. The reason we have this data, I'm going to tell you, I think we have the best Department of Public Health in the nation. It leads the nation in terms of our understanding of the epidemiology of hepatitis C. And these data are allowing us to see the law we've had on the books no longer matches the crisis this Commonwealth faces. So I live in Framingham, and some of you may know we transitioned recently from a town to a city. And it gave us an opportunity to think about who we wanted to be as a city and what our commitment was to the residents of our city. And I was looking at our data on hepatitis C, but it was the whole county. And you know how Natick and Ashland are. What we wanted to know was what's happening in Framingham. What's our obligation to our community in our city? And so I had the Department of Public Health cut the data for us just in our city. And what you can see, the red lines are the baby boomers, basically. And we're just finding some baby boomers, about the same number every year. The big rise is in our youth. And we found out our young people, ages 15 to 29, we have a 50%, higher rate of hepatitis C than the rest of the Commonwealth. We have a youth crisis in Framingham. And because we now know it, we know we need to put in place programs, whether it's our community health centers, whether it's Metro West, whether it's program Rise I'm involved in, to help improve care for our youth. This needs to happen across our Commonwealth. An important study came out recently. This was done by senior folks at the CDC down in Georgia, our own Department of Public Health here in Massachusetts, professors at BU School of Medicine, particularly Dr. Linus, led this study, and some other people, I don't know, some institution like Stanford or something. What they did was they modeled a bunch of different ways of testing people for hepatitis C. You test this age or this group, risk-based, all these things. I'll tell you, whenever people say risk-based testing, get worried. Because first of all, there's lots of people that don't know their risks. Or they, maybe they think, I only shared with one person, my wife, my loved one, I can't possibly be at risk. Or they don't know, or they don't want to talk about it, because unfortunately we still have a lot of judgment, we still have a lot of shame about hepatitis C, and that's a whole other issue. But in any case, risk-based screening pretty much doesn't work, and so we need to have some broader way, and I can tell you from my experience of testing tons and tons of baby boomers at BI, everybody's like, well, doc, if that's what you think I need, of course I'll get it. There has been no pushback, and when people get diagnosed, they're grateful that they found out an important thing, and they now can get treatment. Oh, and the reason we can treat everybody in Massachusetts, unlike maybe Florida, is first of all, we have almost universal insurance, and don't think that's not important, because I talk to people all over the nation, and my colleagues that are trying to do similar work in other states have a world of pain, and they actually will say, Massachusetts, you can just shut up, because your experience is irrelevant to what we're facing in other states. We need to be proud of the health care we can deliver in this state. And the second thing, I've heard rumors from people in other states, we have some of the best contracts around procuring, buying hepatitis C drugs. Actual numbers are confidential, I don't know them, but my impression is we've done a good job of making this affordable in this state, and that's also really important. We have very, very aggressive programs to help make sure that everybody who needs treatment, and that's everybody with the infection, are able to get it. Okay, so in any case, back to this study. What they found was a test of everybody age 18 and older is more cost effective than any other testing strategy they looked at. you find more people, you treat more people, and you have fewer people getting devastating complications like liver failure and liver cancer. So we have CDC sort of sanctioned data that says this is the cost-effective approach. And this is for nationwide. Go ahead. Many of you have been involved with thinking about the opioid crisis, and what I'm going to argue is hepatitis C testing is part and parcel, complements all of the other efforts that we're doing in the state in terms of the opioid crisis. What we learned from the tragedy in Scott County, Indiana, that small community, like, I don't know, 4,000 people and 215 people got infected with HIV because of needle sharing. What kind of got lost in that story is almost everybody already had hepatitis C. Hepatitis C is like the canary in the coal mine. If you've got a hepatitis C outbreak, you have the settings for people being at risk for HIV. And so finding those new outbreaks in our youth of hepatitis C, they need to be addressed in and of themselves because we don't want anybody to have hepatitis C, but we also need to redouble our efforts, vaccinate for Hep B, vaccinate for Hep A, and start looking at preventive measures for HIV. And so this is sort of an added window into our opioid crisis when we do broad testing for hepatitis C, especially because we have such a good Department of Public Health epidemiology that allows us to actually take advantage of these data and mobilize resources and programs. Bye-bye, Mr. Mann. Okay, so we need to prevent acquisition, and this is expanding our needle exchange. We've got, you know, a lot of programs that have come up in the last couple of years, including Framingham, thank goodness. We probably need more. We need uniform access across the state. We shouldn't have to make people go miles and miles to try to do needle exchange. And we obviously need increased treatment to treatment facilities. And then the other thing I'm going to argue is we need to be able to bring treatment to people. And so this is one thing with, say, Program RISE, which is an intervention program. It has a needle exchange component to it. People come there who are not going to come see me at Israel Deaconess in Boston. They maybe can't get there, they maybe don't feel safe there. They feel safe in Program RISE. And there's programs across the state where people will come for help because they feel safe and supported. And we need to figure out ways of bringing treatment to those programs where people are. Okay, so this is the bill, in case anybody forgot, that we're arguing to support right now, Senate 1303. And the next, I showed you our current bill. This bill has very similar language, but instead of 1945 to 1965 birth cohort, it substitutes every person over the age of 18. And that is because the Commonwealth has recognized we now have a youth epidemic. This is no longer a baby boomer epidemic. So the current law is no longer appropriate for the actual crisis that we're facing. And so this is very simple. We take all the lessons we learned around baby boomer testing and we now apply it to a broader population. And there's also language that says if the Department of Public Health finds shifts in the epidemiology, if we can sort of better apply our resources, we can do that. And I trust that because of the great quality data that we're generating, we can keep refining this. But for right now, what we need to do is just go out there and test everybody over the age of 18. Okay, I think that was my last slide. now we get the question. So I think we can.
Want to both field questions?
Yeah, we can all field questions. Kyler, why don't you come up too, just in case? Because it's really important to understand, you can listen to me, but you know, the person who's actually lived with this, what does this actually mean to have hepatitis C? How did it feel to have hepatitis C?
Knowing that having that more than you would without having the disease. And now, for me, I caught it early enough and was tested early enough. I never have to worry about liver cancer. Never. That's one part of my body I never have to worry about. So it's an awesome feeling knowing that it's such an easy test. It's just a simple blood test. That's all it is. You can add it into your regular lab work.
Yeah,
You know?
exactly. Yeah, that's what we do. You know, somebody's going down to get their cholesterol checked or whatever. Oh, you just click one more box, hepatitis C antibody, and most of us now have, if the antibody's positive, you reflex get the viral load, because the viral load shows that you actually have active infection, and then that's people who need to be who need to be treated, and that's the algorithm. It's very simple. Yeah, so this, can I have somebody from the community health centers speak to that? Maggie, do you want to say something?
Sure. My name is Maggie Meiser. I'm a nurse practitioner at Boston Healthcare for the Homeless Program. We have about a 23% prevalence of hepatitis C in our program, and we started a treatment program in 2014. We have almost treated 700 people so far. We treat about 40 to 50 people at a time, and start at least 10 to 20 a month. We built that capacity very early on with support for some grants, from some previous gold grants, and now we've partnered with EndHepCMA, the New England AIDS Education and Training Center, the Department of Public Health, to provide education in community health centers around the state. I'm not the only one doing this. There are a lot of amazing partners across the state, but that clinical education is actively being rolled out into lots of different spaces throughout the state. There's a lot of interest. There's a lot of primary care providers who would love to be doing this with the adequate support and knowledge. It's also an incredibly satisfying area of medical practice to be able to offer this as part of your care, as part of your buprenorphine addiction treatment, your HIV screening, your hypertension management, and your diabetes management. It's all part and parcel of primary care and community health center staffs.
What's the best way for us to support these bills?
So towards the end, once we finish up the question and answer session, for those of you who don't represent legislative offices, I'm going to equip you with the tools to be able to go speak directly with your representatives and your senators. The House bill, H 1955, is still able to be sponsored, so we're still looking for people to sign on to that. The Senate bill has closed at this point, but going to... Is it the other way around? I meant it the other way around. Thank you. That's why we still have the legislative people in the room. So the Senate side is closed, but no, the House side is closed. The Senate bill is still open, so we recommend that you go speak directly with some of the Senate staffers. If that's not something you've done before, approach me, talk to me about ways that you can possibly do that. They're very friendly, and I would encourage you to go and explain to people why this makes sense and why you think that your senator should support this.
Is easier now than it was, say, 10 years ago, and if so, how?
Okay, so one thing you might be picking up on is we used to just do the antibody test, and a lot of people didn't have the viral load done either because it wasn't covered or because people didn't know to order it. And so I had all these people that would come into my clinic thinking they had hepatitis C, and we checked a viral load, it was negative, because about 25% of people will spontaneously clear the virus through their own immune system. And so what a lot of hospitals have done and what Quest and the other big commercial labs have done is put in this reflex testing. So if you get an antibody test and it's positive, it automatically goes to a viral load. And our Department of Public Health, I think, is also doing that. Is that true? Okay, good. And so if you get testing through one of the Department of Public Health sponsored programs and your antibody is positive, the state now will check a viral load. So most people should actually have complete testing done. This bill focuses on primary care. So just like you're going to get notified that you have, God forbid, a mass in your mammogram and needs to be followed up, or you have high cholesterol and you need to come back and talk about, you know, getting started on treatment or diet modification, or, you know, all the other tests that we get done that need to be followed up. The hepatitis C test is just one more. And if your viral load is positive, then the education that Maggie was talking about makes it clear to doctors and all the other health providers, either you're someone who can treat this yourself, or you need to send this person to someone who can treat it. And our state is in a lot better position than a lot of other states in terms of our treating capacity. We still have work to do. I don't want to say that this is perfect. We're in pretty good shape. We still need training. We frankly still need funding for epidemiology and for training and education and all of that. So we have the tools in this state to do what needs to be done and to eliminate hepatitis C. There's still things that need to be sorted.
Can you tell me a little bit about the status of support services for people who are finding out that they're infected with hepatitis C?
It's going to differ based on your facility. And
Is it geography based? So like if you're in Boston, it's better than if you're out in Boston?
Well, different. I'm going to actually defer again to the community health center folks who have a lot of wraparound services. So let's say somebody had their hepatitis C test done within the context of their behavioral medicine program, or you know, maybe their Suboxone program or something. That hepatitis C test is now going to be discussed within the context of the other care that they're getting. As a specialist, I make an effort to keep my panel open. It takes a couple of weeks to get in to see a hepatitis C specialist in probably most of the major health centers, if people are willing to come in. So we do have a little bit of a disparity between our big hospitals. We can get people in very quickly. We can get them started on treatment within a week. In other centers, it's more difficult. I will tell you, one of the reasons that I'm involved with the program I am in Framingham is it's very difficult to get access to treatment in Framingham. And so we have to figure out something different, and that's why we're looking at this model with Program RISE. So I'm kind of interested in why you're interested in this.
My background's on HIV and antibody testing and hepatitis testing, so I know that the testing itself is usually the easy part.
Exactly.
And the support services is the more challenging part. That doesn't make me against testing, but that makes me concerned that we're providing results to people without giving them a safety net of support services.
We do have a fair amount of community-based providers too that are contracted with the Department of Public Health that do a lot of the support that follows community-based testing. So
Do we want to talk a little bit from the community health?
Yeah, so I think Representative brings up actually a great point, and I think it's something I was thinking about when I was in healthcare for the homeless with Maggie's team. I think one of the most successful things was the support services and specifically having case management. And maybe Maggie can speak a little bit to that by having a specific Hep C case manager, because I think oftentimes the community health centers are incredibly burdened with a lot of changing different, moving pieces with healthcare, specifically ACOs. And so I think having this person on point is one of the biggest success factors with treatment in terms of being able to check up on you, make sure you're making appointments, getting your labs. And so I'm just wondering if the coalition is going to be supporting increasing the DPH line item in order to fund more of those programs at community health centers statewide.
So that's a great segue into the shout out for the Project Able Lobby Day, which comes up in 3 weeks now on April 8th. Do you want to speak to that real quick? Just about what the...
Sure. So Project Able is a group that advocates for the HIV and AIDS and Hep C line item in the state budget. And we have an advocacy day here at the State House on April 8th, where we'll be supporting an increase in the line item for the fiscal year 2020 coming up. So,
I was also going to respond. So in terms of, I think the delivery of a new diagnosis of hepatitis C, I think, is an interesting question, and it's we are lucky to be funded for as HIV counseling and testing, that part of the line item, and so the people who are doing phlebotomy, who are delivering potentially HIV diagnoses, are the same people who may be delivering hepatitis C diagnoses.
Massachusetts is doing the best job of any state with trying to get more people linked to care than I've seen around. But again, knowing your status is super important as well, because if you don't know your status, you can't prevent from hurting yourself and hurting others potentially as well. And there's great resources, American Liver Foundation, Hepatitis C, the Advocate. There's a lot of great resources out there that people can go and find. There's also bad resources, but there's plenty of awesome resources.
Do you want to say something about ALF?
Sure. My name's Lindsay. I'm with the American Liver Foundation here in New England. We actually go to a lot of detox and recovery centers myself, actually, and educate and support people and let them know the importance of getting into treatment, regularly referring folks to our community health centers, to our larger institutions. The American Liver Foundation does support this expansion of age-based testing nationally as an official statement. It is available over there. You know, as Cami was talking, I was that baby blip. I was diagnosed at 10 years old. I saw my mom through transplant. I was without that support service. I was burdened by the stigma. And to now know that this is not only something we can easily test for, but we can easily cure in a matter of months. I went through the interferon, and to now be able to go to community health centers and say, there's never been a better time to be tested and diagnosed, because now not only can you be diagnosed officially, but you can be treated very quickly. So I fully support all of this effort, as does the American Liver Foundation, and we have incredible advocates here in the state. So please do consider signing on to this legislation.
I was saying, I was in Florida. I went 7 years just testing, but never offered the treatment. I come here, I get tested in August or September of last year. I was offered my treatment right away. I started my treatment in October. I was done with the treatment in December. You know, so Florida is probably one of the worst as far as offering treatment.
Others worse.
Massachusetts is certainly up there in the healthcare, but we still need to expand to get the younger people, because the younger people are the ones that are really using a lot more now, and they have no idea the potential of the diseases or what the disease can do to them. So they're the ones that we really need to get to.
I think testing opens the door to a whole bunch of other, you know, we always need to be worried that we could cause certain harms. But I think the vast amount of evidence shows good comes from testing. You know, just in terms of being able to direct our state resources, counseling people about ways they can change their lives, and because we do have access to treatment in this state.
I think the one argument that I just also wanted to touch on before we close out is also the economic argument to be made about this. We talked a lot about the cost effective, we talked a lot about patient outcomes and improved health quality outcomes. The real challenge of not doing this, aside from lives lost, is the cost that we're going to face 10 to 15 years down the road, when we have people who went 10 to 15 years without knowledge of their hepatitis C status are now advancing through fibrosis, whereas they could have been put into that pool that Cami was talking about before of you've been treated, now you fit with the people who have never had hepatitis C. The downside of not putting more people into that pool is 10 to 15 years down the road, we're going to need a lot more livers than we have available for people. So we don't want to get to a crisis where we see hepatic cancers skyrocketing through the roof, where we see fibrosis resulting in 10 to 15 years of life ending sooner, and we also don't want to see that cost burden on the healthcare system that's already overbearing with costs as it is. The cost of early intervention and treatment is substantially less than working with someone as they advance through end-stage liver disease or onto hepatic cancers.
So I said, you know, if you haven't developed cirrhosis, you get put back in the pool of people who never had hepatitis C. If you've developed cirrhosis, you now get ultrasounds every 6 months for the rest of your life. And every 6 months you wait for someone to tell you that you don't have liver cancer. It's a completely different reality if you have cirrhosis. And so you absolutely want to find people and treat them and cure them before that. It's a personal cost as well as just a financial cost for our health system.
Say, look, I got treated early enough. I don't ever have to worry about liver cancer, never, because of finding out and being treated. Had I not, you know, liver cancer hits. Now what do I do?
And it's 8,000 cases per year that we're seeing. So starting the early intervention and treatment process now means treatment as prevention works in the hepatitis C world as well. The more people we treat, the less of a public health epidemic that we have, and the less of a cost epidemic that we have 10 to 15 years down the road from now. Did you have a question?
Yeah, can you clarify why risk-based testing isn't sufficient?
Yeah, so I actually was involved with the CDC around the baby boomer testing modeling back in like the late 2009, 10 time. And at that time, we had risk-based testing for hepatitis C since 1998, 2008. So at least 10 years of risk-based testing. And when you looked at big healthcare systems like Kaiser, Geisinger, your wraparound, programs, 3, 4, 5% of people had been tested, and most people were being tested because of life insurance, or some other reason why they had to get, a whole panel of tests, and one of them happened to be hepatitis C, and then they find out, or they tried to donate blood, and they get a scary letter, you need to go talk to your doctor. That's how most people were actually getting diagnosed, even though we had risk-based testing. And it's because there are like 15 or more things that are supposed to be the risks that you're supposed to ask. And whenever I give talk to primary care doctors or any doctors, and I show that list, they start laughing because you've got 15 minutes, and you're not going to spend any moment of that 15 minutes trying to go through all of those questions, some of which are stigmatizing, and some of which, unless you feel really comfortable with somebody, you might not say, 10 years ago I did inject drugs. I'm in recovery. I haven't done that for 10 years, because people often know now you're going to look at me differently. And so if it's not an issue right now, maybe I don't want to talk about it. Or maybe I am thinking about coming into recovery, but I just don't want to deal with it right now. There's a lot of reasons why people don't want to talk about certain things. And then really what we found with the baby boomers was there were a lot of risks that they didn't even know they had. So they woke up in the hospital, they had no idea after their motorcycle accident whether or not they got a blood transfusion. Or I had a bunch of people who the only thing they could think was medical procedures. Because as somebody who trained in the late 80s, early 90s, I think about things I did as a young doctor we would never do now, because we understand universal precautions, because we understand how HIV is transmitted, and in decreasing risk of HIV transmission, we actually ended up doing a great job decreasing the risk of transmitting hepatitis C and other infections in the medical setting. But I think just about, I was sort of on the younger end of that group, all the people that got exposed to medical procedures because we didn't understand universal precautions. So those are some of the reasons why risk-based just doesn't work. It seems like it should, and when I was talking to the CDC around modeling, ever using injection drugs was such a strong predictor. They really had trouble sort of moving to view anything else. But then when they realized that you put a cylinder on people of 1945 to 1965, you captured a bunch of people, and a bunch of people who had advanced liver disease. And I will say that was the right thing for us to do for the last 6 years. But you saw the data, that's no longer our epidemic. And I think the kinds of things that we worry about in terms of stigma and everything hold true with our younger people as well. Now, if you're in a program like Program Rise, where you're doing a lot of counseling around harm reduction, so you know what people are doing, you build in your testing. And so we're regularly testing for HIV and hepatitis C. That's different than what we're talking about with this bill, which is people who are just coming into their primary care office and getting offered the test. Is that good?
Yeah, thank you.
Okay.
So,
do we have statistics about reinfection?
So I'm not sure in this state, do we have data in this state around reinfection? Yeah. Nationally, the studies that have been done, it looks like in people who inject drugs, it's in the 5 to 7% range that are reinfected. And one thing I point out to people is if you are trying to identify and treat people for the sake of also decreasing transmission, if you see no transmission, you're failing in your job. You expect a certain amount of reinfection, because if I already have hepatitis C, I can't get reinfected. But if I'm at high risk for acquisition, I'm also at high risk for transmission. And if I get cured, I now can get reinfected. We will see some reinfection. And thank goodness our insurance companies in this state allow people to be retreated if they are reinfected. And so I've had a couple of people who were reinfected. Interestingly, they've been spontaneously cleared. There's an increased likelihood that people will spontaneously clear after they've been cured with antiviral treatment. And yeah.
So Dr. Talal's work in New York, they're doing telemedicine, treating hepatitis C patients in methadone clinics through that PCORI grant. And the first 45 patients that he treated, he got a 93% SVR. One person stopped meds, so 45 people, one person stopped. 2 people of the 44 left reinfected themselves, so he got a 42 out of 45 cure and sustained virologic response. So it was similar numbers to your 5, that's probably 5%, right? Again, the numbers are small, but 2 out of 45.
It's not 50%.
Right.
It's single digits, Maggie.
I was gonna say, I think one of the most powerful arguments around screening is if you can screen and treat as many people as possible, the pool for reinfection goes down.
Yes.
So if you are treating a community of people who are at risk to reinfect each other, you treat them all, they're not going to do that.
What we worry about though, if you treat one and I treat one and somebody else treats one and they go back out into a group of people and you know that are still infected, the likelihood they're going to get reinfected is higher. If we can treat as many people as possible, and there's lots of really cool modeling. I mean, you've just seen the tip of the iceberg. I could talk for like 24 hours, like some sort of marathon about this. Yeah.
I was gonna say there's some great modeling data on this that the best, so you know there's a World Health Organization goal to eliminate Hep C in the world by 2030. And the United States is not even close. We're expected not even to get to this by 2050. But the modeling suggests that if you scale up Hep C treatment as well as harm reduction services and addiction treatment together, that this will be that's the best way to achieve this goal.
And
so I think they're hand in hand.
Our state probably could achieve this more rapidly than any other state. We have all of the elements. We have an understanding and acknowledgement of the opioid crisis and a will to do something about it. We've got the resources to do the hepatitis C testing and treatment. I think we've got bills like this that I think will help highlight where our issues are. Yes, and we just need to get in there and start treating people.
I think something else that's super important is like Lynn Community Health Center, for example, like knows their number, right? Until you kind of know your number at your facility of what the number is. So back in the day, I heard Dr. Freiling talk, and he gave a presentation last year. In 2015, Lynn Community Health Center treated 25 patients. And then they upped the number of treaters, and they went to 85 the next year and 125 the next year. But if they didn't know they had 1,400 patients, they would have thought they were doing awesome with treating 25.
Yes.
Until you kind of know where you're at. So HRSA has websites, and actually in Massachusetts, I've looked it up. So in the year 2017, there's over 10,000 patients positive in the community health centers right now, and I'm sure that's way underestimated.
That are waiting for treatment?
That
are waiting for treatment?
2017, there was 10,000 positive hepatitis C patients because hepatitis C is a reportable disease. So if you looked at all the community health centers in the state, 10,000 unique individuals were seen that year with hepatitis C. So whether they're treated, mostly they're probably not treated, right? Because we're not having, we're doing a great job with Deb's program through the NEATC, but getting more patients known and the providers at these community health centers. I think the work that they're doing to try to get more patients treated is tremendous.
This bill will not fix everything, in case anybody's under that illusion. And we will need additional resources. And I know people get scared, like, oh, you're starting down a slippery slope, and pretty soon there's going to be. But we did this kind of know what this is going to look like. And when you have more people, you figure out how to figure out your resources, whether it's the case management or training new health providers. You know, we're smart people in this state, and we can figure this out, and we may need additional state support for various things. And so I don't want the message to be, oh, we're doing a terrible job right now, and if we add more people, it's going to get even worse. I don't think that's true. And I think there's a lot of folks that would be willing to learn how to do hepatitis C treatment because it is so easy now compared to how it was. So yeah, it's just a matter of kind of getting a few elements together. One of the big elements is all the people who don't know that they have it.
So I think to close out, just have a few closing messages. First, thank you all for coming today. I really appreciate your presence here. Second being, I really wanted to thank the Office of Senator Mark Montigny. A couple of his staff are here today who sponsored the initial bill and worked with us in the past on this issue, as well as Representative Jack Lewis, who is promoting this on the House side. So my last couple thoughts that I wanted to share with you, especially for those who are here in an advocacy capacity, if you could take 5 to 10 minutes before you leave the building today to just go reach out to your senators and to your representatives to let them know this is an issue that you care about, that these specific bills are issues that you care about, but that hepatitis C in general is something that you want on their radar. I think hepatitis C, it's been called the silent killer for years because so few people understand it. There's very little public awareness about this, despite the fact that it kills more than the next 60 infectious diseases combined. There should be a better public awareness about this, and that starts with all of us. So working to, one, promote these bills, but also working to walk into that office and make sure that they put hepatitis C at least on their radar when they see things coming across, when it comes up in conversations in the committees, that it's something that they're advocating for and that they're passionate about because their constituents are passionate about it. And I think that's the most important thing that you can do, is walk into their office, let them know that you are their constituent, and let them know that this is something that you want them to prioritize. If anyone wants to do that or wants pointers on how to do that or would like to know who their representatives are, you can come up to me afterwards and I can quickly pull that up on my phone. But other than that, I would like to encourage you all to take as much coffee, donuts, and muffins as you possibly can, because I can't take those back to my office with me as much as I would love to. So please feel free to take those on your way out. Please feel free to sign in if you didn't. Take some buttons, take some information. The information will be really helpful if you are going to go to your senator's or representative's office to be able to not only say some words, but also put something in their hands so that they have some information to read off of.
Can you describe procedurally where these bills are and what the timeline looks like?
The timeline is right now, so they're up. They're both have been referred to the Joint Committee on Public Health, and they're awaiting hearings at this point. Correct? Basically?
That's
okay.
really all we have right now.
Right.
So we have a hearing date, which could be next week, or it could be
right. So we're very early on in the process, but the more that we can get information out and the more that we can advocate, because the other thing that we're also advocating for is the line item that supports the funding for all of the programs across the state that do this, and that's what's going to be taking place on April 8th if you're able to come. There's information about that on the agenda, and you can reach out to me for more information about what that event is about and how you can attend it.
I just wanted to ask, we're from Cambridge, and there are a number of, I think, interested local journalists. Do we send them to you? Do we send them to the offices? What do we do?
You can absolutely send them to us. I'll happily talk to any journalist about this topic.
Yeah.
Any opportunity we can get. So thank you all very much for coming. Like I said, please feel free to take some Dunkin' Donuts. Feel free to take anything on the table over there. And if you'd like to come chat with me about how to go find your representative or your senator, I'm happy to do that with you at the end.